Okay, again, we've already kind of talked about respiratory assessment with the patient. I'm going to kind of pinpoint a couple other things for you guys as well. When we're assessing the patient's respiratory patterns, we want to look at respiratory rate, depth, and effort. Okay? When we're talking about normal breathing, it should be effortless and quiet, right? All of you guys sitting here listening to this lecture, kicking back, relaxing. It's nice and effortless, nice and quiet. We have good chest rise equally, bilaterally, and fall, right? We know that our tidal volume is adequate because we're seeing that chest rise and fall. Plus, we also do have good skin color. We have good mentation. We're alert and oriented to person, place, time, and events. We're not confused. We're not irritable. We're not combative, right? And then when you guys listen to lung sounds in the lung fields, they should be clear. All you should kind of hear is the swoosh of air in and out of all the lobes in the lungs. And we're going to talk about lung sounds here in a sec as well. Remember that when we're talking about assessment, this really starts as soon as we make eye contact with our patient, right? We are kind of doing this all at once, right? Kind of getting the general impression of our actual patient themselves to see how they're actually perfusing. Patients in respiratory distress, they may be restless. They could be combative. They might be verbally combative or possibly even physically combative. We're going to talk about something about hypoxic rage, where the brain has been so starved for oxygen, we kind of switch into this kind of primal fear, I guess is the best way to put it, where we develop almost superhuman strength, and that can actually be detrimental to you guys because you guys are going to have to wrestle with these people or these patients. But basically what this is we're working a little too hard to get the oxygen. It is up to us as EMTs to find out why this patient is working too hard in order to get their oxygen, okay? Remember that when we're dealing with somebody with shortness of breath, every single word that they speak, every single time that you guys ask them a question, specifically something that they need to elaborate on, it is taking energy. Okay? So if we see somebody in shortness of breath, we should automatically, 100% without a doubt, throw them right on some oxygen. In order for them to kind of catch up, let's ask them some yes and no questions at first, in order for them to kind of catch up on their respiratory rates and their gas exchange. And then hopefully our patients will be able to elaborate a little bit more on the questions that we are asking. But every word or every movement that we are putting our patient through, okay, is going to increase the demand for any oxygen in our body in order for our cells to produce energy for us. So when we first make eye contact, we want to see the general appearance of our patient. Going back to that gentleman in the slide, right, he was very anxious. He was wide-eyed. He was very skinny, right? He didn't have a lot of fat on his body, right? You can see his muscles moving. You can see the actual muscle, the intercostal muscles kind of contracting, even with just a still picture there, all right? So when we're looking at general impression, is our patient anxious? Okay, technically, anxiety could be seen as an altered state of mental status, right? They've just been sitting there all day watching Family Feud on TV, and for whatever reason, they develop short of breath, and now they're becoming very anxious because they're not able to satisfy their air hunger. Okay? What do they look like? Are we dealing with a Bubba, right? Do we see oxygen tubing around them? Do we see an oxygen tanks around them? Do we see inhalers, medications specifically for respiratory illnesses? Right? And based on that general appearance, really what we're trying to do is, specifically at the EMT basic level, is try to tell ourselves, is my patient sick or is my patient not sick? Okay? If they look sick, let's make a transport decision right then and there. Okay? By looking at them. We have looked at the A, B's, and C's, right? Let's get them in the back of the ambulance and let's get going, right? My patient is anxious. I can see that they're using a lot of muscles in order to help them breathe. And my patient might be a little pale. They may be a little sweaty. They may be in that tripod position. They may be emancipated, okay? let's make a transport decision right then and there, right? Are we going to stay and play? Are we going to load and go and do everything in the back of the ambulance? Okay. And again, make sure that you guys are looking around the environment for medications, home nebulizer setups, oxygen tanks, oxygen tubing, any kind of oxygen delivery devices that our patient may be using. How is my patient positioned? Okay. Are they sitting upright? Okay. If they're sitting upright, right? If my patient's sitting there and they're sitting upright, I know that they are able to get that good chest expansion for adequate gas exchange in order for them to make sure that they're getting the tidal volume that they need, because I can see that equal bilateral chest rise. Is their skin pale? Is their skin pink, warm, and dry? Right? If their skin's pink, warm, and dry, I know that they are perfusing all the cells in their body in order for good, adequate gas exchange. If they're pale, I know that possibly we have a problem with gas exchange. Okay. Are they tracking me as I approach? Are they answering my questions appropriately? Or when I ask them a question, are they asking questions, or are they answering questions in 2 or 3 word bursts because they are so out of breath? Things that you have to kind of start considering when you're doing your respiratory assessments. Tripod. Again, this gentleman is basically kind of sitting in a tripod. Okay, he's sitting down, he's leaning forward, he has his hands on his knees. All right. This is kind of a false feeling of adequate breathing. Okay, when you guys go and exercise, let's say you guys go and you guys go for a run. Okay, when you guys are done with the run, they always tell you don't put your hands on your knees, right? Because technically it's harder for you to breathe. It might feel good, right? It might feel good to you guys, but it's harder for you guys to breathe. It's going to take you longer to relax. When you guys go for a run, that's why they always tell you to interlock your fingers and put your hands on top of your head and try to sit up as straight as possible, right? To kind of help with getting that chest to expand in order to use less energy for your muscles to have to increase the interthoracic pressures that we need in order for adequate gas exchange. Okay, so that's tripoding. That gentleman that you see in this picture is in the tripod position. He's sitting down, he's leaning forward, and he's got his hands resting on his knees. Okay, when you see that gentleman, you would want to try to do your best to have him sit back in that chair. Okay, try to relax. Let's throw him on some oxygen, more than likely some high flow oxygen through a non-rebreather, anywhere between 10 and 15 liters per minute. Let's get him started on that oxygen. Let's have him start huffing and puffing that oxygen in, and let's give him a couple minutes before we actually start asking clarifying questions. Okay, are they sleeping propped up on pillows, or what we call orthopnea? Okay, orthopnea is kind of a positional shortness of breath, right? Some people have to sleep in their lazy boys. They can't lie flat. If they lay flat, they actually become more short of breath. And we're going to talk about that a little bit later on in the specific respiratory emergencies that we're going to cover in this lecture. Okay? Or is your patient complaining of shortness of breath as they're lying down? Well, hopefully this would be a no-brainer. But if your patient is lying down and they're complaining of shortness of breath, one of the first things that you guys should do is sit them up. Right? Let's sit them up. If they do have fluid in their lungs, okay, if they do have some kind of fluid, whether it be pus or blood or just regular edema, right, by them laying flat, that fluid is actually covering more surface area of that lung than it should. So if we sit them up, we're using gravity to push that fluid down into the base of their lungs, hopefully trying to recruit more alveoli for adequate gas exchange. So if your patient's laying flat and they are complaining of shortness of breath, first thing that you guys should do, sit them up. Next, we want to evaluate their speech. Okay? First of all, can they speak? All right? Do they have the ability to speak? If they're not able to speak, is this something normal? Do we have another underlying condition that is preventing them from able to speak, such as like a history of stroke or something like that, or some kind of traumatic event? Okay? So can the patient speak, right? And listen to what your patient is saying. Listen to what your patient is saying, okay? Some things that you might hear is like, I can't breathe. Okay, that might be a ventilation problem. They might have a problem with breathing in and out. Okay, something that we might have to address. It hurts to breathe, right? Maybe they say it hurts when they try to take a nice deep breath in. Maybe it hurts where they can't expand their chest appropriately, like if it's a traumatic event, right? If they've suffered some kind of trauma and possibly have some broken ribs, it's very painful to breathe. Again, if you guys have never broken a rib, right? It is very painful to breathe with a broken rib, okay? Or does it hurt to breathe because they might have pus or fluid in their lungs, right? Or if they just tell you that they just feel like they can't take a good, satisfying breath in, or they just feel like they can't get enough air, these all kind of mean some different things. But either way, we're going to treat them pretty much the exact way, specifically at the EMT basic level, okay? And again, can they talk at all? Okay? Are they breathing so fast, right? Are they using accessory muscles? Have they been starved of oxygen for so long before they actually decided to contact 911, right? That they can't talk at all, right? They're so focused on breathing. Are they speaking in 2 or 3 word bursts? Can they sit there and actually talk like I am right now to you guys in complete full sentences? If they're sitting there and they're talking in complete full sentences and they're still complaining that they're short of breath, right? We could have, they could be BSing you, right? They could have what's called a pulmonary embolism, right? Different things that can go on. Just something I want you to kind of put in your pipe and smoke, put on the back burner, and really kind of start thinking about when we go into our respiratory assessments. Changes in actual mental status, okay? If we have a drop in O2 to the brain or a lack of O2 to the brain, it's going to seriously start affecting the patient's mental status. They could be confused. They can be very anxious. They might look like they are having a hard time focusing or possibly even very sleepy, all right? Or if that hypoxia is really bad, they could seriously become extremely aggressive with you, both verbally and physically, or kind of show some type of bizarre behavior. They can't sit still. They're very restless. They keep wanting to try to get up and go clean the dishes for whatever reason, okay? These could be signs of hypoxia, all right? So just because somebody has altered mental status, I don't want you guys thinking, oh, well, this patient might just be on some kind of mind-altering toxin like alcohol or drugs or something, right? This could be 100% oxygen starvation related. Skin color. Guys, I can't stress this enough. Remember that the skin is an organ. The skin is the only organ that we can see. It's the cover of the book. It makes us want to see if we actually want to read it or not. Okay, the skin can tell us a lot about our patient. I want you to look at this lady that's on the slide here. Okay, we've never met her, right? We don't know what her normal is. However, I can see that her lips are a little blue. Okay, that is a sign of cyanosis. Okay, she looks a little pale to me, but you know what? I guarantee she's probably answering questions appropriately, right? She could be A&O times 4. She might be a little restless. She might be starting to get anxious, but we have signs and symptoms of cyanosis. And I know it's hard to see in this picture, but if you guys look at the tip of her nose, okay, the tip of her nose is actually just a tad bit more pale than the rest of her body, which is also going to start developing into a cyanosis, okay? She is not perfusing herself adequately. For whatever reason, we are not getting good, adequate exchange to these parts of the body, and more than likely it's because this patient happens to be hypoxic. Let's give this lady some oxygen and kind of start from there, okay? But when we're talking about skin, normal is warm, pink, and dry to whatever ethnicity the patient is. If the patient is African American, they should be a nice dark color, okay? When African Americans get pale, they actually get what's called ashy. They actually almost turn gray. The darker the skin, the grayer the skin. Okay? Now, I'm not saying it's just our African American friends, our Caucasian friends, right? All the white folk out there, when they look pale, they can also get gray and ashy too. But we're going to talk about that a little bit more when we get into cardiac emergencies. Okay, you guys will always be able to see cyanosis on the patient. That's just kind of the bluing of the lips. Could be the bluing of the actual tip of the nose. They can have sunken in eyeballs, real kind of dark, purpley colored circles around their eyes, not necessarily looking like black eyes, right? Like they've been punched, but there's just this kind of purplish, dark blue tinge around their eyes. That is cyanosis, okay? Pallor. Pallor is just a sexy way of saying pale, okay? And modeling, we're going to talk about a little bit later. Modeling kind of, they could be like flushed. It can look like certain parts are like red, other parts are really pale. We're going to talk about that in specific disease processes. There's some pretty severe modeling. I would say that is a cadaver that is actually showing modeling. And again, we'll talk. Okay, so when we're talking about work of breathing, how do we actually see if our patient's work of breathing is progressively to start really kind of talking about going between a respiratory distress to a respiratory failure? The big one is accessory muscle use. Okay, going back to that gentleman in the first picture that we saw, you saw those accessory muscle use. He is working very hard to breathe. He's using a lot of energy, both with inhalation and exhalation during the breathing process. He's going to get tired real quick. And when people start getting tired to breathe, that's when they crash on you. Okay? So that is somebody that we definitely want to get oxygen on real quick. Pursed lip breathing. Okay? We see this in a lot of respiratory disease processes. And really, when we talk about pursed lip breathing, the patient is actually trying to create back pressure for themselves in order to stent open the alveoli to help with gas exchange. So think of this as kind of like the CPAP, right? Kind of creates a little bit of resistance when they're breathing out in order to help stent their airway open in order to maximize the amount of gas exchange. So pursed lip breathing is when somebody kind of breathes in and then they kind of push their lips out a little bit, right? In order to kind of breathe out in order to create that back pressure. So it sounds kind of like this. It's like, right? They kind of put their lips together in order to, see, even me trying to do it makes me cough, right? But that's what pursed lip breathing is. And if you guys really want to see it, just Google it. Just Google pursed lip breathing, and you'll see patients that are actually pursed lip breathing on the web. Open mouth breathing, when we're talking specifically about children. Now, babies themselves are technically mouth breathers until they reach a certain age. But when we have kids that are open mouth breathers, that's a sign that they're working a little too hard to breathe. Nasal flaring in children, right? So they're kind of popping out their nares, kind of trying to suck in as much oxygen as they can. That is a great sign for work of breathing in children. And head bobbing, guys, head bobbing in kiddos is a very scary thing. When we talk about pediatrics later on this semester, we have a whole lecture based on pediatrics. When we see head bobbing in kiddos, that kid is getting tired. Okay, now I'm going to just say this real quick. I don't want to spend too much time on this, but children are resilient. Okay, they'll be sitting there, they'll be talking to you, everything's going to be fine. You might notice some nasal flaring, you might even see some head bobbing, and then boom, they're dead. Okay, there's no in between. Like, you're going to see like this kind of gradual progression of decline in your adult patients. Okay, kids don't do that. They're happy, they're glad, they're talking to you, they're answering questions, and boom, dead. Okay, they just don't have the musculature. They don't have the developed bodies in order to compensate that much. So they're going to crash on you pretty quick. We'll talk about that more when we get to pediatrics. Some common breathing patterns that we might see. That regular pattern, you guys can see they're breathing in, they're breathing out. They're breathing in, they're breathing out. Cheyne-Stokes, we've already talked about. These are very common in head injury patients and possibly stroke patients. It's kind of a rapid sigh followed by a period of apnea back into a rapid sighing. And there's some good examples of that on the internet. You guys can Google that to see exactly what that actually looks like. Kussmaul's respirations is actually specific as far as the EMT basic goes. It's specific to an endocrine disorder known as diabetic ketoacidosis. Some of our diabetics, when their sugars levels get too high, they actually go into a Kussmaul's respiration, which is actually a deep, rapid sigh. You guys can look that up as well. And I'm going to talk about Kussmaul's a little bit later when we actually talk about the endocrine system emergencies. And then we have agonal respirations, which is basically taking a fish out of the fishbowl and throwing them on the table and watching them die, basically, right? We also call it guppy breathing, right? Where it's really not a respiratory pattern. It could be very irregular. The patient is still, yes, quote unquote, breathing, but there is absolutely no gas exchange at all. We can see this in traumas. You guys will see this in certain medical conditions, which we'll talk about specifically when we get into those. Okay, some patients might be so short of breath or have some kind of disease process that's going on where you can actually hear them breathing without any stethoscope use. Okay, so noisy breathing is basically obstructed breathing. Okay, something could be obstructing anywhere in the upper and lower airways. Something's going on that we have to address. Okay. So these are just some examples that I kind of threw on this for you, okay? We have a separate lecture on just lung sounds. Please make sure that you guys are listening to those lung sounds so you guys kind of get an idea of what those noisy lung sounds are like. And really, once you guys have your equipment, you guys are listening with your stethoscopes, please make sure that you guys are listening to your family members. You guys are listening to your doggies, your kitty cats, if you can get them to sit still. I don't care what. Lung sounds is a skill that needs to be practiced and practiced and practiced. You guys need to listen to 1,000 normal lung sounds before you're actually going to hear what abnormal might be. But some of them are pretty obvious. I'll let you guys read over this slide. What I do want to point out here is stridor is technically the only upper airway lung sound that you guys are expected to know. All these other ones are lower airways. Okay, I know that gurgling says fluid in the upper, all right, but really you're going to hear gurgling all the way down in the lower airway as well, specifically in the lungs. When you guys hear fluid in the lungs. So right now, as EMT basic, stridor is your only upper airway adventitious lung sound. We'll talk about stridor here in a sec as well. Okay, I jumped ahead a couple slides, specifically the slides on stethoscope use. I think that's pretty much self-explanatory on how to actually put the stethoscope into your ears to hear the best. And then the kind of the points with the auscultation of the lung sounds both on the front and the back of the body. Make sure you guys look over those slides. So when we talk about auscultate or auscultation of the lungs, we are using our stethoscope to do this, okay? And we're going to ask ourselves a question: are our lung sounds clear and equal bilaterally, okay? We also want to observe, does our chest rise and fall equally? Is it unequal? Okay, is only one side of the chest rising and falling and not the other side of the chest? These are all kind of clues on what's going on with our patient. If we only have one side of the chest rising and falling, more than likely we could have a lung that has been pierced or probably has a hole in it. It could be deflated, okay? And we call that paradoxical movement, okay? Paradoxical movement. We're going to talk about paradoxical movement a little bit more when we get into trauma. Okay, pulse ox. When we're talking about the pulse ox, this is what the pulse ox looks like. It's actually a little machine that we put on the end of somebody's finger. We also have like pulse ox strips or pulse ox tape, which some services call. That's actually something that we can tape on to the surface of the skin. We can connect to somebody's earlobe or whatever in order to monitor their oxygen levels in their blood. And that's exactly what this machine is doing, is monitoring oxygen levels in the blood. Okay, I put the normal ranges in there. Now this is for National Registry standards. For our class standards, remember we want them as close to 94 as possible, 94% as possible. And yes, anything below 85% is problematic to us. Okay, this is something where you guys might want to start thinking about even throwing that patient on the CPAP with a little bit of PEEP. Probably set at 5. Set your PEEP at 5 for this patient, just to kind of get them caught up. And remember, you can always take it off and put them on a non-rebreather after that or something. But 85% is a little bit too low than what we want. There are some caveats to the pulse ox. Anytime the patient has cold extremities, we will not get a reading. Okay, whenever you guys start getting cold in your fingertips, your blood actually is shunting back to the core of the body. So we might not even be able to get a reading on the pulse ox. And we're going to talk about that a little bit more when we talk about shock. Shock in general, it's going to be hard to get a reading on the pulse ox, no matter what type of shock it is. Again, if we have a patient that's in shock, our blood starts leaving our peripherals, right? We don't need our blood in our fingertips at that time. We don't need our blood in our toes. We're going to start shunting that blood, or kind of squeezing that blood back up to our core in order to keep our vital organs functioning. That is the whole purpose of shock, okay, is to shunt the blood back to our core. It's a natural defense that our body has. Unfortunately, it's very detrimental to us. It can kill us, right? But your extremities could technically go quite some time without blood flow. We're going to talk about that specifically in trauma and tourniquets, right? But we'll talk about that in trauma. Carbon monoxide poisoning. Carbon monoxide actually has more of an affinity to the hemoglobin, so it's attracted more to the hemoglobin that are sitting on our red blood cells. And it has such an affinity to our red blood cells that it can actually knock off oxygen molecules, giving you guys a false reading on the pulse ox, okay? But make sure that always in EMS, okay, we treat signs and symptoms. We do not treat numbers, okay? We treat signs and symptoms. If your patient is pale, I don't care if your pulse ox says it's 100%. This patient needs oxygen, okay? Treat the patient. Do not treat numbers in EMS. Okay, guys, I skipped ahead on some pediatric differences as far as their anatomy. We're going to cover that again in the pediatric lectures, but you guys can go back. It's just 2 slides. You guys can go back and read it. Basically, just remember that pediatric airways are smaller than the adults, than the full-grown adults. That's really the takeaway from those two slides that I skipped over. However, this slide is a great way to kind of point out what inadequate breathing is. I'm not going to go over all these. You guys can read this slide over yourself. But these are definitely some signs and symptoms of inadequate breathing. And as you guys can see, there's quite a bit, right? So again, respiratory system is very important to us in EMS, in medicine in general, right? But we do specialize in the respiratory system when it comes to EMS. This is our cup of tea. And we want to make sure that we are maintaining our training, specifically on the skills and the tools and the equipment that we use, and be able to be good detectives when it comes to somebody that is complaining of some kind of respiratory complaint, whether it's short of breath or whatever. Some things to consider when we have somebody in respiratory distress is, once again, we do not want the patient using energy to talk to us. Have them write them down if we need to. Ask yes and no questions, and really focus on more important questions. Okay, ask them how long this has been going on. Do they have a history of any kind of respiratory illnesses? Take a look around the environment to see if you guys can see oxygen tanks, oxygen tubing, medications, anything like that, in order to help kind of pinpoint what might be going on with this patient. Remember, we are doing assessments in order to rule stuff out. We're taking a big picture and funneling it down to see exactly what we need to be able to do for our patients in order to sustain the quality of life that they had before they called 911. Okay, so you guys have already kind of talked about the OPQRST scale in lab. Really, we use this for pain mostly, but we can use this for anything. We can use this for shortness of breath, okay? Remember that O is for onset, right? What time or how long have you been suffering from this, okay? The current event, okay? The current event, all right? The onset and time are two totally different things. We're going to talk about time here in a minute. But how long have they been suffering from their shortness of breath now? Okay, provocation and palliate. Does anything make that shortness of breath better or worse? Right? If you take a deep breath in and kind of hold it for a little bit, does it feel better for you than just kind of regularly breathing in and out? Okay, does it hurt? Is it hard to take a deep breath in? Does it feel like you can't get enough air when you do take a deep breath in? Questions like that. Quality. Okay, what does the shortness of breath feel like? What I like to use for quality, even with pain, is if you wanted me to experience, I will ask my patient this. If you wanted me to experience the exact same thing that you are experiencing right now, what would you do to me? Okay, you're going to get some great answers with that. But man, it really kind of puts stuff in perspective for you. Radiation is kind of tough when we're talking about shortness of breath, but radiation for like pain. Does that shortness of breath or pain stay in one spot, or does it go elsewhere, right? Does it shoot to your back? Does it shoot up your neck? Does it shoot down your leg, right? Where is the origin of pain, and does the pain stay right there, or is the pain moving around the body? Severity is your 1 to 10 pain scale, 1 being no pain, 10 being the most pain you've ever felt in your life, or if we're doing it as respiratory, 1 being no shortness of breath, 10 being the worst shortness of breath you've ever experienced. Where are you at? Okay, time. Okay, time is how long have you been experiencing this shortness of breath, right? Not necessarily for this moment. Okay, this is where we're going to start kind of going into the history of the patient, right? Well, I understand that you have a history of COPD, sir. I know that you are basically always short of breath. What makes this short of breath worse than the last shortness of breath? What's different about this shortness of breath today than the other days? Okay, and you is there to remember, has this happened to you before? And if so, if you went to the hospital, what did they do for you, or did they diagnose you with anything? When it comes to getting your sample history, remember sample, the S is signs and symptoms, A stands for allergies, M stands for medications, P stands for past medical history, the L is what was your last oral intake, and E is events leading up to you calling the events leading up to the patient calling 911. Sample is very important for us. Sample is something that you definitely, if you do have somebody that's short of breath, you want to maybe try to whip out a little bit earlier, just in case this patient does go unresponsive, at which point they won't be able to answer your questions. All right. But really, when we're talking about samples specifically for respiratory, are they allergic to something? Could they have been exposed to something that they were possibly allergic to? Okay, that could have caused this respiratory distress. Any medical history of any respiratory diseases? Do they take medications? And are they taking their medications as prescribed? Okay, are they compliant with their medications? Right? And then look around. If they're not able to talk, look around the house for any medications that you might find, specifically inhalers. Most of the, I guess I shouldn't say that. Some of the respiratory medications do come in an inhaled form, or a MDI, a multi-dose inhaler for our patients. So keep a lookout for those as you are kind of getting your general overview of your scene.